So welcome everyone and thanks for joining us today for the Choosing Wisely April webinar. My name is Anne-Marie Martin and I'm the Choosing Wisely Health Services Lead. Firstly, I would like to begin by acknowledging that I'm hosting this meeting or webinar from the lands of the Wurundjeri people of the Kulin Nation. I also acknowledge the traditional custodians of the various lands which you are all dialing in from today. Pay my respect to the elders past, present and emerging as well. So thanks for joining us, and also a warm welcome to two new champion health services. So we have Northern Territory Health, who are using a statewide approach to implement Choosing Wisely, and we also have Eurobodalla Health Service in New South Wales joining us as well. So we have 48 champion health services implementing Choosing Wisely across Australia, which is great to see. So I'd like to pass over to Professor Nola Rees, and she'll be discussing defensive practice, medical legal risk and low value care. Thanks, Nola.
Thank you very much, Anne-Marie, and welcome to everyone. And thank you for joining the webinar this afternoon. I am joining from Awabakal country and also pay my respects to elders past, present and emerging. So we have two objectives in the webinar today. And I will just advance my slides. So I will share some findings from research I conducted with doctors and healthcare consumers on the topics of defensive practice and low value care. And I will also highlight a new online learning course that is really based on and a response to the findings from this research project. So those are our main objectives over the next 20 or 25 minutes or so that I will talk, and we'll leave some time for some questions or discussion at the end. So just by way of brief background on the research project, some of you may have some familiarity with it from previous presentations that I have given. And the project was funded by the Avant Foundation and investigated medical legal drivers of low value care. And my main collaborator in this research was Dr. Jesse Jansen, who was formerly with Sydney University and has since moved to the Netherlands and is now at Maastricht University. So the project investigated defensive practice as a driver of low value care. So I will start with a few definitions so we're all on the same page, and these definitions are likely familiar to you. So defensive practice refers to clinicians ordering tests and procedures, making referrals, prescribing drugs, those kinds of things. And these practices are done mainly to reduce perceived legal risks rather than because the clinician feels it's really necessary to advance the patient's diagnosis or treatment. And when I refer to legal risks, for the purposes of this research, we interpreted legal risk quite broadly. So it could be a formal complaint or litigation, or it could encompass any other kind of investigation, an internal workplace investigation, for example, where a clinician's practices come under scrutiny. So defensive practice is by definition low value. So this delivering services out of legal defensiveness does drive low value care. And low value care is defined as care that is of no benefit or where the harms or costs disproportionately exceed the potential benefit for the patient. And according to practitioner surveys, defensive practice is quite common. So as part of our project, we started off doing a literature review study. So we looked at empirical studies of physicians' views and experiences of defensive practice. We ended up looking at 79 articles published in a range of countries. And it was, in general, around 70% or more of doctors, particularly who responded to surveys, said that yes, they engage in various kinds of defensive practices. And notably, these studies were done in countries with a range of healthcare systems and different kinds of legal frameworks. So it seemed that the legal or healthcare model in which clinicians were practicing doesn't necessarily have that much effect on whether or not they practice defensively. We also found in this literature review that there has been a lack of research on patient perspectives and experiences in relation to defensive practice. So in our research, we wanted to try to fill that gap as well. So our study, after doing that literature review, we devised a key informant interview study. So we interviewed both, or I conducted the interviews. So I had the privilege of speaking with a number of doctors and healthcare consumer representatives. And by key informants, that meant that we were seeking experienced clinicians and experienced healthcare consumer representatives who would have given some thought and reflection on issues around defensive practice and low value care. So as you can see, I conducted interviews with doctors who had interests in medical legal issues, with clinicians at Champion Health Services, and in general, those interviewees, the medical practitioners, had at least around 20 years of experience. And the healthcare consumer representatives were recruited from peak bodies for healthcare consumer organizations. And they too were very experienced consumer representatives or advocates. So they tended as well to have around 20 years of experience as a patient. So somebody who had a lot of experience accessing health services, or also providing care for a family member with complex illness. They had formal roles sitting on hospital committees as a consumer representative or on complaint bodies. So we were able through these interviews to gain some deep insights onto the topics that you can also see listed on the screen. So we wanted to find out about clinicians' experiences with defensive practice, consumer awareness, what seems to drive this legal defensiveness, what are the impacts in terms of that patient-clinician relationship, and importantly, what are some solutions? So I wanted to briefly mention the theory that informed our research. So we were guided by the theoretical domains framework. So it encapsulates theories of behavior and behavior change, and is commonly used in implementation work and research. So the TDF identifies 14 domains and these are things we should pay attention to if we are trying to implement new practices, for example, to improve delivery of higher quality and safer care in health services. And likewise, this theoretical domains framework can inform de-implementation strategies. And looking at defensive practice and low value care, we can see it as a de-implementation challenge. How do we move away from being legally defensive and delivering low value care out of perceived legal protection and substitute that low value care with something of higher value? So the TDF, as I mentioned, covers 14 domains. Based on that literature review, we identified 7 domains that seem to be most pertinent to defensive practice. So you can see the 7 domains that we selected. So the interviews were really organized with questions that related to topics like knowledge, skills, sense of professional identity, and so on. So I'll comment a bit more about findings as they relate to those particular domains. So what did I hear in these interviews? So in terms of clinician perspectives, I heard that defensive practice is one of several drivers of low value care. So all of the clinicians I interviewed felt that defensive practice was a concern in the Australian healthcare context. In terms of its connection with low value care, yes, it was seen as a driver of low value care. Other drivers of low value care were described as lazy medicine and mercenary medicine. So we've got defensive practice that delivering low value care out of legal defensiveness, lazy practice just engaging in habitual patterns of sending people off for tests or procedures and not really questioning those practices. And the mercenary practice was described as relating to the financial incentives for delivering services and being able to bill for them. So there are a range of complex factors that relate to or drive low value care. But focusing in on defensive practice, a common message was that it is underpinned by a general anxiety about missing something, missing a diagnosis and some kind of harm coming to a patient, and a sense of getting into trouble. And defensive practice is done to avoid both formal legal risks, but also reputational risks. And a very strong message that came through in the interviews is that doctors described being perfectionists and also being competitive and often quite hard on each other. So it was more a worry about peer criticism that drove defensive practice rather than a fear of formal legal sanctions. And one of the quotations that really conveyed that message, we used it in the title of the paper, so it ended up being a very long title for an article. But one interviewee said it's easier to talk about our fear of lawyers. So it's easier to say, well, we do these things to protect ourselves or for a perceived sense of legal protection. And it's easier to describe it that way rather than talk about our fear of looking bad in front of each other. So I'll come back to that concern around peer scrutiny and criticism. So in terms of patient perspectives, a message from the healthcare consumer representatives I interviewed is that defensive practice really goes against patient expectations. So patients would not expect that clinicians are sending them off for potentially unnecessary tests or treatments or procedures to cover their legal backside. They articulated that most patients think doctors do no harm, and patients want to put themselves into the hands of experts who will act in the patient's interests, not trying to protect their own legal interests. The consumer representatives commented that the idea of defensive practice implies an antagonistic relationship instead of partnership. And partnership was the major theme that came through all of the interviews with the healthcare consumer representatives. So they really stressed that in their journey of becoming quite experienced healthcare consumers and advocates and so on, that they see partnership as being key to good care with a patient. So they really thought that this idea of doing things to a patient for legally defensive reasons is counter to what patients expect in their interactions with healthcare providers. So I'll focus now a bit more on some of the specific factors that came through in the interviews as factors that influence defensive behaviors or practice. And I mentioned earlier that this desire to avoid peer criticism came through as a strong message. So within these domains that influence behavior, that was an example of a social influence, how group norms and influences can drive particular kinds of behavior. And a strategy to avoid that then would be to avoid shaming and blaming individual practitioners. So one interviewee, a clinician I interviewed, said medicine is not infallible. Things can and do go wrong, even for a clinician that is providing good care, acting at a standard of a reasonably competent clinician in their area of practice. Things still do go wrong. So it is important when things go wrong that there is a supportive response rather than that individual blame and shame, which just simply motivates more defensive practice. So in the environmental context or organizational context, came up as an important theme here, this idea that there need to be good supports when things do go wrong. If there is a formal complaint or some kind of legal process that happens, those also need to be managed well. And that sense that there is a complaint hanging over a clinician's head, again, would drive more defensive behavior. And there was also a sense, too, that organizations need to back doctors up. So this was a reference to Choosing Wisely initiative. So if an organization is really promoting choosing wisely, then they need to back up a clinician who then says, well, I am going to resist doing particular tests or procedures. And then if something does go wrong, that they are supported. And there was this general sense in the interviews that it is still easier to defend why you did some kind of test or procedure rather than to defend why you did not do it. So that was an important comment at that level of social influences in organizations. I'd like to focus in now more on the practitioner level, so practitioners' knowledge and skills. So in terms of knowledge, an important message that came through in the interviews was a sense that there's room for improvement in clinicians' understanding of the law, that there can be a sense that the law is often very harsh or draconian. Those were words I heard in the interviews. Although it was commented, again, going back to the point that doctors can be hard on each other, there was a sense that doctors can be hard on themselves as well, that they self-impose or peers impose a standard of perfection. And then that self or peer imposed standard then becomes interpreted as what the legal standard is. So there needed to be reinforcement that the law sets a standard of reasonableness. So it would be really reassuring to reinforce the message that the law is founded on what is reasonable and does not demand an impossible standard of perfection. In terms of knowledge, the other key issue was a lack of attention to harms of low-value care. And one clinician pointed out that everything we do, there's a cost. So there can be a cost or risk of harm to individual patients. And there are also costs in terms of misallocation of healthcare resources. And the healthcare consumer representatives also shared their perspectives on what they saw as some of the harms of being sent away for low-value tests or procedures. So they talked about a waste of money, a waste of their time, that if they're being sent off for further investigation, they have to deal with anxiety during that period where they still feel they don't know what's going on. So they very clearly felt that there were harms of low-value care. So in terms of skills, so the aim is to de-implement defensive practice and low-value care, then having good skills in clinical reasoning and patient communication were highlighted as essential to that de-implementation exercise. And we would then want to substitute that low-value care with something that's of higher value. And that was often described as having more time for good conversations and communication with patients. So time to discuss options, risks, benefits that leads to better quality, consent to care, and so on. So there was interesting discussion around time constraints and patient characteristics. So one clinician observed that they felt that doctors do have the skills to communicate, that it's often time constraints hinder their ability to do so. And sometimes there can be kind of an attitude that against this idea of sharing and discussing with a patient. Around patient characteristics, there was conversation about patients being very demanding and being unyielding to evidence-based conversations. But a positive finding was that the clinicians felt that was a small minority of patients. So they felt most patients were open to those kind of conversations. And the healthcare consumer representatives, again, reinforced that they think it's important to have those good conversations. They recognize that sometimes it's not easy, it's not fun, but it is part of bringing patients along a journey of improving health literacy and being more active participants in their care and decision making. So in the last 5 minutes or so, let's turn to solutions. So, and in talking about solutions, it's important to acknowledge that this challenge of reducing or preventing defensive practice and other drivers of low value care requires strategies across a range of levels. So it can be at that macro level, public education campaigns on avoiding unnecessary care. So choosing wisely public education campaigns. I've commented briefly around that organizational level and the importance of fair and efficient complaint processes, support for clinicians if things do go wrong. But I'll just comment mainly here on the individual level. So coming back to the role of training or education to support knowledge about the law and attention to the risks of low value care and better communication. And that brings us to highlighting the new course that is available. So again, it's based on findings from this research. And it's really focused on the strategies that were identified in our project. So this table is from the paper I mentioned earlier that presents the findings from the clinician interviews. So the aim of the training is to provide an overview of core legal standards to improve awareness of the risks of low value care, and also to provide access to some practical resources for time efficient communication with patients that can support better communication and decision making. So the course, it takes up to an hour to complete. It has interactive features, so you can self-assess, do little quizzes as you go along and work through the material. It's based on current research, so there are links to relevant articles. Assuming you might not have time to go off and read a bunch of things in BMJ or MJA, we have short audio summaries that will provide the key messages from some of those resources. And there are some scenarios based on actual court cases where you can read through the clinical scenario and weigh up whether you think the doctor in that scenario acted in accordance with legal requirements. So we did do a pilot evaluation of the beta version of the training, and the feedback was positive that the training did provide relevant knowledge and information that could be applied in practice. The clinical scenarios based on real cases were quite popular, and the clinicians involved in reviewing the pilot version also felt that they came away with a better understanding of their legal obligations and risks of low value care, and some strategies they could use to avoid those kinds of practices. But now that the training or the course is available to a much broader audience, we are keen to continue that evaluation. So we encourage you to go in and check out the online course. There is a short survey to do at the end to hear your feedback. There is an opportunity to participate in a follow-up survey if you would be happy to receive a short survey down the track, so we can hear a bit more after you've reflected on the training and perhaps had an opportunity to try to implement some of the strategies in practice, how that went for you. And again, being mindful that any initiatives to try to promote choosing wisely, we really do need multi-pronged initiatives. So an online course certainly isn't the only strategy. So we are keen to explore opportunities to integrate the training that might support other initiatives you are pursuing within your organizations. So if you have some ideas or interests around embedding some kind of evaluation that would incorporate the training into other things you're doing, certainly get in touch. There might be an opportunity to pool some resources and brainstorm some strategies to continue to evaluate this. And there's seems to be a little bit of a lack of evidence too around what kind of interventions work in terms of improving that knowledge and skills to reduce defensive practice. So I think it's important to continue to do that work and build that evidence base as well. So that is everything I wanted to say. So I might just stop sharing the slide, and if we've got a few minutes left for some questions or discussion.
Great, thanks for the insights, Nola. You do have a few questions in the chat if you're happy to go through them, or if you're having trouble, I can read them out for you.
I am just having a scroll through. So a comment around negotiation, so mediation. So yes, that's certainly a good point that many kind of complaints or disputes, there certainly is an emphasis on earlier resolution. I would hope that legal principles still play a role in that, but would be interested to hear more about that. And then so a message is that defensive practice does carry legal risk. So anytime if a patient is sent off for a procedure that the clinical justification is poor and something harm comes to that patient, then yes, there certainly could be an argument that there has been a breach of the legal obligations owed to that patient. And it's something that one of the interviewees said, that it becomes legally indefensible. So that's why there was a strong emphasis on paying attention to those risks of low value care. So there is an interesting question around lack of access to information about what kind of tests or procedures a patient has already had. So duplication might happen. So in that sense, that would be another kind of driver of low value care. It might not be a legally defensive motivation. The reference to My Health Record is interesting because the healthcare consumer representatives really endorsed those kinds of ways to improve access to information about tests and procedures, things that they had already had as part of their history. So they really wanted to see better sharing of information as well, and use of those kinds of systems. They also gave some practical suggestions more for the individual patient to make sure they're keeping good records or symptom diaries, and they really emphasize that whatever the patient can bring to provide information about their own history, that is really helpful. So I think another positive message is that the healthcare consumer representatives really felt that patients do have responsibilities as well. Connecting patients with peer support groups can be really helpful. So they did not think that the burden of communication and improving decision-making just rests solely on the shoulders of busy clinicians, that there, again, needs to be a bit more of a holistic approach to having consumer-facing resources that can help them, so that when they come into that time for a consultation, that they're a bit better prepared. So how many modules in the course, how long does it take? So up to 1 hour. So it really depends how much time you might spend accessing some of the links in the resource. So it's divided into 3 sections, but otherwise it's most people who were part of the pilot, they kind of went in and they did it in one go, and were able to digest all the information in one go. And the link has been put up there. Thank you, Carl, for adding the link. And I think those are all the questions I can see.
Right, so thanks, Carl, for the link. The module is also available on the Choosing Wisely website under resources as well, if you have trouble finding it. Any last minute questions for Nola before we wrap up? I think that's it. Thanks so much, Nola. It was a great presentation, and someone's just saying thank you from Lisa there from Mercy Hospital. And also it's been great developing the module, and hopefully it's something that can be integrated into a lot of onboarding processes, but also used by clinicians already at your health services too. So thanks everyone, and we'll see you for the May webinar, and hopefully for the national meeting on the 3rd of May as well. So if you haven't registered, please feel free to register on the Choosing Wisely website. Thanks again.